Good morning, all. We have a case live in box case from Apollo Main Hospital in Chennai. And I'm Dr. Refai Showkathali. I'm a senior consultant interventional cardiologist. So we have an interesting case to present today and to proceed on. So we have a 39-year-old gentleman on the table now who has got effort angina and dyspnea for the last 6 months. So over a period of last 2-3 months, it's gradually worsened. He underwent a series of tests in his local hospital, and ECG showed a sinus rhythm with a ventricular rate of 64, and there's no significant abnormalities on the ECG. The echocardiogram showed a good left ventricular systolic function with ejection fraction of 65%. So he underwent a treadmill test. The treadmill was strongly positive for inducible ischemia, and therefore he underwent coronary angiography in the local hospital. So this is the first. On the left-hand panel is the LAO caudal view, which is a spider view, which is showing us that the left main seems to be reasonably okay. But there is a significant disease involving the ostium of the left circumflex artery, and the LAD ostium is also involved with stenosis involving around 70%. And the right-hand panel is a PA caudal view, which is also showing that an obtuse marginal artery, which is coming from the proximal part of the circumflex after the stenosis, is reasonable size, and there is a 70% narrowing involving the proximal part of the obtuse marginal artery. Again, this is another caudal view, so showing the same images. And then we have on the right-hand panel is the PA cranial view, suggesting the length of the lesion in the LAD. As you can see, the LAD lesion is quite a long lesion, more than 25-30 millimeter, up to the septal branch after a large diagonal as well. Even though the stenosis is not that severe, but it's a reasonable 70 to 80% stenosis up to the mid part of the LAD. So this is the RAO cranial view, once again suggesting the length of the lesion in the LAD on the left-hand panel. And we know this gentleman is actually a left dominant system, and you can see the right coronary artery is small and non-dominant. So having seen this angiogram, he has been explained about the, next slide please. He has discussed about the options of coronary artery bypass surgery versus angioplasty to the left main LAD bifurcation. So as we all do, the first thing I did was a syntax score, and the syntax score of the 2 lesions involving the left main LAD circumflex bifurcation and also the obtuse marginal were included, and the syntax score 1 was 12. Suggesting that it's a low syntax score. Obviously, as we know from the data, that the low syntax score can be treated both with CABG as PCI. And I calculated the syntax score 2, which is a combination of factors, including the anatomical syntax score and also the other factors such as creatinine clearance, the left ventricular ejection fraction, and this COPD and peripheral vascular disease and age, which suggested that the 4-year mortality for CABG is around 1%, and the 4-year mortality for PCI is around 2.5%. So no significant difference as such, but we have discussed all these options with the patient himself, and the patient decided to go for PCI to the LAD circumflex and left main. So the strategy for us today is, considering it's a left dominant system, it's got a good left ventricular function. I decided to have a 7 French glide sheet slender on the right radial axis, which is the main axis for PCI. And considering his left dominant system, and we're going to treat the left main, I also have an arterial axis at the right femoral with a 4 French Cordis sheath. In case if I need to put an intra-aortic balloon pump, it's better to have an axis ready during ballooning of the left main. So with this, we can start the case. The plan was actually, considering his angiogram showing the circumflex artery is a reasonably large size artery, and this is a left dominant system compared to the LAD, I decided angiographically that I may be using the left circumflex as the main branch and the LAD as a side branch for a DK crush technique where we can put 2 stents. We know the evidence has suggested that the DK crush technique is one of the best techniques for bifurcation PCI in bifurcation disease. So we have taken some pictures of the 7 French guiding catheter. So as you know that we always see some differences from the angiogram versus the pictures we take during the angioplasty with the larger guiding catheters. So one of the things I noticed that the LAD seems to be not too bad after a diagonal branch. An initial plan was for me to do the stenting from the distal to the septal branch. But looking at the images now with the RAO cranial and the PA cranial, the guiding catheter, with the good injections, I can see that the atheroma below the septal branch is not that significant. So I'm planning to stop my stent between this diagonal and the septal branch, just above the septal branch. And the caudal view once again showed me the nice bifurcation angle, which is more than 70 degrees. And once again, it proved that the circumflex is the larger artery of the two. And I'm going to keep my strategy as using the circumflex as a main branch and the LAD as a side branch and do a DK crush. Nevertheless, I'm going to do an OCT run for both the LAD and the circumflex to assess the size and then start the procedure. So let me just wire the circumflex first. So what I've done is I've wired the circumflex with our dynamic roadmap, which is the new Philips system. And the wire is in the circumflex. So I'm going to do a OCT run first from the circumflex into the left main to assess the disease in the circumflex and also assess the size of the distal reference vessel of the circumflex and the left main as well. So I've not wired the LAD now just because sometimes the OCT run may not be that smooth with the second wire. So I'm trying to avoid the second wire first, but the next time I'm going to do a LAD wire and also do a LAD pull back as well. So the OCT catheter is in the mid part of the circumflex, as you can see. Shall I give some nitrates, please? So I've got the OCT catheter in the mid part of the circumflex, which I think is a reasonable size of the circumflex, which is not diseased. So I'm going to do an OCT run from there. So I've given a 200 microgram of nitrates NTG into the circumflex, and we're going to take a picture of the OCT now. So that is the OCT run. Right, so the next step we did after taking a OCT images of the circumflex, now we got a wire into the LAD and we got a OCT catheter into the LAD. I'm going to do the same OCT pullback from LAD into the left mainstem and to see what the size of the LAD is. So we just done a pullback from the LAD into the left mainstem. So we have a OCT pullback from the circumflex to the left main. As you can see, it's a nice pullback. The images are very clearly, except the last distal most part of the vessel was little clearance issues, but otherwise the pullback was clean. And you can see there is a significant disease of the ostial circumflex as it comes through, and the left main is a large left main. And I'm going to show you some images, clips where we measured the size. So start from the distal. So this is the distal landing zone I'm thinking of in the circumflex, about 8 to 10 millimeter below that obtuse marginal branch, where there is a reasonable clear zone. And the measurement I got is around 3 millimeter through 3.25 in diameter in orthogonal views in that segment. And then when we pull back, just drag through. So you can see the areas on the top. As we can see, this is not too much disease as such. Come back, but there is some evidence of atheroma there. And you can see the obtuse marginal branch coming in a minute. Come back. That's the OM branch coming here. There is some disease in the circumflex there. This is the, and come back more. There's the OM branch joining the circumflex in the proximal. There's a little bit of thin rim of calcium seen, but not very heavy burden of calcium in the 3 to 5 o'clock position. Come back there, and now we are getting the significant stenosis of the circumflex. You can see the luminal area is around 1.6 with the measurements of diameter measurements. You can show the diameter measurements there. Yeah, so the length we are getting is 1.7 was 1.3, and area is getting 1.62, which is quite significant stenosis of the circumflex ostium. Come back now. So again, the extending, there's not a lot of calcium seen, but it's a thin rim of calcium, as you can see there. And now you can see the ostium of the circumflex is involved, so you can never put a stent into this ostial circumflex. You have to come back to the left main. Play that. So this is the POC, and that's the ostial circ. Yeah, that's the ostial circumflex. You can see that LAD is coming there. So there is a disease burden at the ostium circumflex. People tend to think that they can put a stent from the ostium of the circumflex. That is where the mistake happens, because you can see the ostium is significantly involved there with a heavy burden of atheroma, and we always have to stent from the left main. So come back to the left main now. So this is coming into the left main. You can see the area, it's 9.6, not much of a disease burden in the left main. As we all know, it's a Medina 011 bifurcation disease. And we just wanted to see where we're going to land the stent. We are not going to put from the ostium of the left main stem. So the landing zone is around 8 millimeter proximal to the ostium of the circumflex. And at the landing zone, we are getting a luminal diameter of around, that's not much of disease, 4 versus around 4.85 is the luminal diameter. There's very minor amount of disease. So assuming this, I would expect my stent size to be around 4.75 to achieve a diameter of 4.75 with the stent. So that is the decision-making process to decide what is the length and diameter of the stent you want to put from the circumflex. So my decision here, having seen these images, is I'm going to put a 4 by 30 millimeter stent coming from the circumflex into the left main stem and use a 4.5 or a 5 millimeter balloon to post-dilate the proximal optimization. And this is the LAD to left main pullback. Once again, it's a very good pullback. You can see the LAD, we are starting from the 15 millimeter below the septal branch, but what it shows is that there is not of significant disease up to the septal branch. Only there is some atheroma starting from the septal branch coming up to the diagonal, and you can see that there is a diffuse disease of LAD up to the proximal part bearing the ostium of the LAD. And as you know, the left main, the clearance was not great in this view in the left main, but we have a clear images of the left main in the circumflex. So the left main is around 4.75 in diameter, and I think we should achieve that with our stents. So having seen the OCT images, so we know that the LAD size, distal diameter of the LAD reference vessel is around 2.75, around 3, and the distal reference vessel diameter of the circumflex is around 3.5 to 3.75. Having seen that, we decided to pre-dilate the lesion. So far, we have not any dilatation while the OCT was on, so that's interesting that the OCT runs smoothly. So we started to dilate. Next smile. So we started to do a 2.5 millimeter sequential inflation in the circumflex and to the LAD. Next one. So this is a 2.5 millimeter by 15 balloon into this circumflex. Next one. So we use for the LAD is because next one. Next one. So these are all at around 14 atmospheres, and yeah, this is the ostial LAD, which is around 2.5 balloon at around 16 atmospheres. Next. Next. So then we started to use a 3.5 balloon for the circumflex. Having seen the circumflex is large vessel, we wanted to make sure that we get a 3.5 balloon inflation. So we took a short balloon, but unfortunately at the ostial segment, the balloon got slipping so frequently. It's a 3.56 balloon. So we decided to take a long 3.5 balloon to pre-dilate the ostium. And this is the 3.5 by 15 millimeter balloon at around 16 atmosphere at the ostium of the circumflex, and this is the next picture we took. So you can see that the lesion was pre-dilated very well with the 3.5, and the LAD lesions are also pre-dilated. So we're going to go for the stenting now. So the first stent we are going to decide to put is the LAD stent, which is going to be a 2.75 by 30 millimeter onyx resolute. So coming back into the left main for us to crush. So for us, we also need a balloon ready in the circumflex to crush after deploying the stent. So what we have done is we got a stent into the LAD. I think I decided to go for a 3 by 30 millimeter stent, having seen the LAD in the OCT images. So, and I'm just trying to pull back the stent to come to the left main. Okay, take a cine there. So I can actually, that's actually quite good. Come to this spider view. So let's see how far we are in the left main. So imagine that, remember, we are doing a TK crush technique. So I want the LAD stent, which is the side branch for me, to come into the left main. So for me to crush with the circumflex balloon. So I have a 4 bar 8 millimeter circumflex balloon ready for us to crush the stent as we come back. Test, please. Yeah, I can go forward a little bit. Remember, this is an onyx stent. There is a gap between the dot and the stent starting point is around 0.5 millimeter. So we're going to take a picture now. Rather picture. Yeah, we'll see. Okay, we'll see again in the cranial view. Let's make sure we are not landing in the plaque segment. So we're going to go to RA cranial. So the idea was to stop the stent just proximal to the septal branch. Okay. I think that looks okay to me because the stent is actually at least 1 to 2 millimeter proximal to the septal branch, and show the previous picture, which is the spider view, and see, and there is at least 3 millimeter or 2.5 millimeter into the left main, which is exactly what we wanted for a DK crush. Now screening. Okay, you can start test again one more time. Yeah, yeah. So you can 2, 4, 6, 6, 8. Yeah. So because the LAD at the mid segment is not too high, I'm going to deploy the stent as a nominal. 10. Yeah. And down, please. Yeah. PA cranial. Let's make sure there's no distal dissection. So what I've done is I've just pulled the stent balloon back 2 millimeter, and to go at a little high pressure, go up there. 10, 12, 14. That's enough. So we're just optimizing the ostium of the proximal part of the stent before we crush with the circumflex balloon. And down. Yeah. It's exactly what it wanted to the LAD stent to be. So now I have go to the spider view, please. So we deployed a 3 by 30 millimeter LAD stent from the mid part of the LAD up to the left main stem as protruding into the left main around 2 to 3 millimeter. Then this is the picture which I took after deploying the stent, optimizing the ostium of the LAD stent. You can see nicely opened up LAD stent there. And next picture, please. So then I had my 4 millimeter balloon ready for crushing the stent in the circumflex. Next one. So it's actually a 4.5 millimeter balloon. Next one. So this is the crushing of the LAD stent, 4.5 millimeter at 8 to 10 atmospheres, nicely crushing the LAD proximal part of the stent. Next picture. So this is the last picture after crushing the LAD stent. So I need to rewire the LAD through the proximal stent strut. Can I have another wire, please? So we crushed the LAD stent with a 4 balloon, and we thought the 4 balloon went up to 12 atmospheres. There was a little bit of slipping of the balloon, but then we thought we managed a reasonable crush. So then I tried to rewire into the LAD through the proximal strut. So you can see the wires went reasonably okay. And then I wanted to decide to do a kissing balloon inflation, but this normal balloon was not passing through the LAD. So I wanted a stent boost and see where exactly my wire has crossed through. And then I realized that the wire has actually crossed through the stent struts and not across the stent struts. Next one. So I decided to remove everything and then do a more further crushing, this time with a 4.5 balloon. Next one. Yeah, so this is the 4.5 millimeter balloon crushing to make sure that I crush the LAD stent properly. So I won't do the same wiring through the stent struts, and rather wiring through across the stent struts. So now you can see the next wire. Next one. So this time you can see the wire going through the stent struts into the LAD stent, and then I managed to make sure that the stent boost to make sure that the wire has gone through. And the next one. And this stent boost will showed me that my wire has crossed through the stent struts and not through the luminal of the stent. So and then I did a first kissing balloon inflation, so sequential inflation to the LAD with a 275 balloon and a 3.5 into the circumflex. And this is the first kissing inflation with the same 275 and a 3.5 into the circumflex at 12 atmospheres. And stop. And now I removed the wire. I'm taking one last picture after removing the LAD wire and balloon, and this is what we got. Now we're going to put a stent into the circumflex. So now I've decided to put a 4 millimeter diameter stent, 34 in length, from the circumflex into the left main. This is my second stent for the DK crush. So as I said before, I'm going to leave the ostium of the left main without stenting. because I know the left main ostium is not involved. Picture. I can come back a little bit more. Yeah. And pull the guide back. I think that seems to be reasonably okay for me to deploy the stent. Go slowly. 2, 4. 2, 4, 6, 8, 10. 10. So that's it. 10. 10. Not more than 10. Just keep it at 10. Come down to 8, please. 8, down. So this is the deployment of the circumflex to the left main stent. So we chose from the OCT images, we chose that we'll put a 4 by 34 millimeter in length, 4 millimeter in diameter, stent from the circumflex back into the left main. And you can nicely see that the stent is coming up to the shaft of the left main, and we deployed it around 12 atmospheres. Next one. So this is the image we immediately took after deployment of the stent. So just make sure there's no distal edge dissection. There is no distal edge dissection. And then we did the first pot. This is a 5 millimeter NC balloon pot at the proximal part of the optimization technique. We went up to 12 atmospheres, having known that it's a 4.75 vessel. So I didn't want to go too high pressure with the 5 millimeter balloon. I went up to 12 atmospheres with a 5 millimeter NC balloon. And then we started doing a second kissing inflation this time. So this time we have a 4 millimeter balloon into the circumflex and a 3 millimeter balloon into the LAD. So you can see the sequential inflation, LAD first at 14 atmospheres and the circumflex at 14 atmospheres. And then we did a kissing balloons at 12 atmospheres each with a 3 millimeter balloon into the LAD and a 4 millimeter balloon into the left main to the circumflex. Next one. So this is just to take a stent boost pictures, and this is the shot after doing the second kissing inflation. And then we want to do a repot after second inflation. This is again with a 5 millimeter NC balloon. At this time I went up to 14 atmospheres with a 5 millimeter NC balloon. Next one. And then we decided to do an OCT run. So the first OCT run was from the circumflex into the left main. Circumflex into the left main. This is the first OCT pullback after deployment and report, and you can see the pullback on the top screen. It's a good position of the stent. The expansion is absolutely fine, and you can see the diameter of the stent. There is no distal edge dissection, and the diameter of the stent at the left main is well opposed. As you can see, and we have a lumen area of around 17.3 with an expansion of around 340. Remember, this is a long stent, so it's assuming from the distal segment, it's given an expansion of 373 in the left main, but the edge of the stent, the distal edge of the stent looks clean with no dissection, and we got an area of around 5.8 to 6.25 millimeter square millimeter into the distal part of the stent. Then we did the next pullback, this time from the LAD to the left main pullback. As you can see, I'm going to show you the pullback from the left main to the LAD on the OCT. So you can see the LAD is also expanded very nicely, the stent, and the expansion is quite good. There is no malapposition, and there is a very minimal stent expansion, slightly less in the ostium of the LAD when we looked at it, but actually when I looked at the cross-sectional area at the ostium of the LAD, it comes around 6.5 millimeter square. So I was quite happy with the left LAD ostium. I didn't want to go back and re-expand it. The distal edge of the LAD, there is no dissection. And again, the left main was not clearly seen on this pullback because of the angulation. But we know from the circumflex pullback, the left main was fully opposed. I think with that, we decided to finish our case. We took last 2-3 images, cine images with the wire and without the wire. This is the PA cranial view. You can see a nice full TIMI3 flow in the LAD with no residual stenosis or good expansion of the stent. And the next one, and the last caudal views to show that the left main is nicely opposed at the left main, and you can see the ostium of the left main is spared without the stent. I I think with this, gentleman will, it's a little long procedure, and but it's tolerated the procedure extremely well. So this is a good demonstration of left main bifurcation PCI with the OCT imaging. It's a DK crush technique using circumflex as the main branch and then LAD at the side branch. There were little challenges when you're doing this, particularly with the ostium of the circumflex, with some melon seeding when we balloon the circumflex, but nevertheless we managed to get through, and it's a good result. And the radial access, now we're going to go with the TR band to close the radial access. Thankfully, we never had any hemodynamic instability to use a balloon pump, and the patient is extremely well, and he tolerated well. Thank you. So having finished the case, so we have a 7-French slender sheath on the right radial. So I decided to put a TR band for hemostasis of the radial axis, so the patient can move his arms very easily. So this is the TR band. So I have a 15 ml on there. So you can show you there. So this is I got a 15 ml air in the TR band, and I'm going to inject slowly and remove the sheath as I inject. Okay, so that's the TR band done. So that will make it much more easy for hemostasis to preserve his radial artery in the future access if we need to. Thank you.